All right, so we're going to jump into lifespan development. Guys, this is pretty much going to cover from birth to geriatric age. There's different age groups that we need to be familiar. A really, really, really big part of the content of this chapter is understanding, especially in pediatrics, right, in the kiddos, their vital signs change drastically the older that they get. So you've got to be very well aware of those different vital signs range, because you might come up to a kid and assess them and get a heart rate on them and be like, holy crap, that is way too high. Something's wrong with this kid. When in fact, it's a normal heart rate for them. Okay, so just make sure you guys are really taking away from this chapter the vital signs. That's a really big one. That's, again, we'll talk about them here, but it's just going to be memorization, okay? All right, here we go. All right, so neonates, this is where we start. From the second you come out of mom until you are 1 month old, you are considered a neonate. All right, they are, for the most part, super small, super dependent on everybody else. There's a lot that goes into their immune system's not nearly developed. There's a lot of responses that aren't really there yet because we haven't been growing and maturing just yet. So neonates birth to 1 month, and you are considered an infant from the second you turn 1 month until you turn 1 year old. Okay, so neonate birth to 1 month, infant 1 month to 12 months or 1 year old. All right, so neonates. Guys, it's crazy how their vital signs are drastically different. They can have a heart rate up to 180 beats per minute, and that's normal for them. All right, little recap. What's a normal range for an adult heart rate? 6,100, 6,200, right? So if you came up to an adult patient, like a 20-year-old male, and had a heart rate of 180, yeah, we got a problem. That's not normal. That's way too fast. But with the neonates, they can go up to 180, anywhere between 90, guys, that's honestly a little low, right? We like to see it over 100, but up to 180 is normal. Okay, so when we start hitting that 200 pulse rate range for these neonates, we need to start considering some treatment and figuring out that that's probably a little too high for them. Okay, what's the normal respiratory rate for an adult? 12 to 20 breaths per minute. All right, 30 to 60 for these neonates, for these little ones. All right, so again, you got to know these ranges, because if I come up to an adult and they're breathing 40 times a minute, that's not good. That's way too fast. We got a big problem, right? But 40 breaths a minute for these little kiddos, it's totally normal. It's to be anticipated, okay? Okay, so guys, the older they get, around a year, we start to level out a little bit with that respiratory rate, 20 to 30. Usually on the little higher end, around that 30 mark is okay. But the older they get, the more normalized their vital signs are going to be to that normal adult range. Okay.
Looks like the range shoots too.
Yes, it does. All right, so blood pressure. Okay. Blood pressure is kind of a funny thing, a finicky thing with these kiddos. What do you think overall their blood pressure is going to be in comparison to a normal adult? Why do you think higher? Okay, so the heart's beating faster. That's a very fair judgment. But they're so small, right? So yes, their heart's beating faster, but their surface area for their body and their circulatory system is much smaller than an adult's, right? It's just, in comparison, a lot smaller. So yes, the heart's beating faster, but it doesn't have a lot of area to cover, right? So it's not going to have to, that left ventricle is not going to have to pump as hard, or honestly very hard at all, to give the adequate pressure for the blood to circulate through that small surface area. Okay, so their blood pressure is ridiculously lower than a normal adult's because they are so much smaller in size. Okay. Now, guys, all of these normal vital signs we're talking about for neonates and infants, this is for healthy kids, right? We're not going to see really any abnormalities with these blood pressures or these heart rates unless they have a congenital defect, right? Unless they were born with a health condition, okay? What else is not coming into play that we talked about yesterday that we can see in adults that can make your blood pressure higher? Okay, restrictions or obstacles. All right, like what? Remember the two types we talked about? Okay, so the plaque, all right, what is that called? Atherosclerosis, right? How did we talk about that happen? How did that atherosclerosis develop? Bad diet, right? What else? Okay, lack of physical activity. Guys, do these kids come out of mom and in their first couple of months of life eat baby back ribs and eat fried food and drinking beer and all that stuff? Hopefully not, right? But no, so we don't have that to worry about. That's another reason that they come fresh, clean, right off the assembly line, right? We're not going to have any of that gunk inside of their vessels. It's not going to create that systemic vascular resistance. They're not going to have that higher blood pressure, okay? What was the other one we talked about? Arteriosclerosis. What is that?
So it's related to age and the vessels get harder, more flexible.
Usually comes with age. It can come with other medical conditions as well. But yeah, the muscular content inside those vessels, they become rigid, they become hard, they can't constrict and dilate, they're not as flexible, and that can cause some hypertension. These babies don't have that, right? So surface area and fresh off assembly line, we're going to have a much lower blood pressure, okay? The bigger the kid gets, the longer they get, the heavier they get, their pressure is going to start going up, right? Because they now have more what? Surface area, right? More tissue, more cells to get that perfusion going. So that left ventricle is going to have to pump a little bit harder to get it to all of that increasing size, okay? Guys, typically when they are born, they range anywhere from 6 to 8 pounds. Can be more, can be less, especially if they're born premature or if mom has any unsavory habits like, like a fetal alcohol syndrome, if mom was drinking or doing drugs throughout pregnancy, they can be born with very low birth weight. They can be born, like both of my kids were almost 10 pounds.
Whoa.
So it just depends on, mom's health during pregnancy and just, I guess, genetics, okay? Guys, they grow at a crazy rate. Like, I wish we could put a time lapse on my kids because it's like, a couple days will pass and it's be like, whoa, these clothes don't fit you anymore. Like, how did I physically not see you growing? It's crazy. So, they gain about an ounce a day. Their weight's going to typically triple by the end of their first year. All right, that's impressive. My son's already well past that. But my 10-month-old's like a Michelin man, guys. Like, he's massive, like defensive lineman material already. Okay. But typically, this is kind of the general range we go by. If they are around tripling that weight, then they're growing accordingly by the end of that first year. So again, cardiovascular system, guys, we'll talk about it when we get to the OB chapter, the obstetrics. I get really geeked out in that chapter because it's freaking insane how we grow human beings inside of us and all the crazy things that happen. But one of the really, really, really cool things, guys, when baby is inside of mom, baby doesn't really have a true circulatory system, all right? It works through diffusion, it works with mom's systems, but once baby is out of mom, it goes from depending on mom's circulatory system to there's a hole in the heart that kind of fuses shut, it closes, and then now baby's having that own circulatory system, okay? So really cool thing that happens. This is where we see if that hole doesn't shut completely, All right, that's where we start to see those heart defects in these babies that are born with these issues when they're not 100% transitioning from depending on mom to being fully functional. Okay.
How, I mean, is that something that occurs instantaneously? Or,
Same thing with the lungs too. There's a really cool thing that happens with the lungs.
well, but I mean, you're saying something closes off. Right? So,
Why it doesn't close before birth, like immediately before, but like as soon as they come out, like what, like that, or
Yeah, like during the process of trial, like, yeah, because certain hormones are released when, you know, mom is actively getting baby out. Baby's brain picks up on that. Mom's brain picks up on that. I'm like, okay, it's time. Let's fix it.
That's crazy.
I know.
Really bad.
It's so cool.
I just
So
delivered
cool.
my son a month ago.
Nuh-uh.
Yeah.
You actually delivered him?
Yeah, he didn't quite make it to the hospital,
No way.
so it was interesting.
It's very interesting. Yeah.
Healthy, thankfully, but yeah.
Hey, that's amazing. So you'll already have that under your belt for clinical experience. Because guys, technically it is within your scope to deliver a baby as an EMT. That is not a paramedic skill or solely a paramedic skill or an AEMT. That is all on you. If it's you and another EMT on the truck and somebody's having a baby, get your catcher's mitt ready. Okay? Crazy, crazy awesome.
It happened to us.
Yeah, congrats, by the way. That's awesome. All right, so their pulmonary system. Let's talk about the anatomy of younger kids versus adults. All right, so is that your first child?
Second, I
Okay.
have a 2.5-year-old.
Okay. Anybody else in here have kids? Yeah. All right, so guys, the size of their head in relation to the rest of their body is ridiculous. They have very unproportionately large heads. What also is unproportionately large? Huh? That can cause airway obstruction. Their tongues. They got massive tongues, right? What do you think the diameter of their trachea, their windpipe is?
less than that.
Teeny tiny. Guys, when they're born fresh out of mom, it's about the diameter of a drinking straw. Okay, so add the super, super tiny diameter of their trachea to a very large tongue, to a very large head that can, you know, position them not in an ideal spot. They're very prone to airway obstructions. All right, so we need to keep that in mind. Their airways are not, oh, never mind, we won't go there. So yeah, just be aware, especially if they're, you know, taking the bottle and they have like they're spitting up, it can really get caught and clogged in that trachea very easily. The tongue can actually kind of flop over and kind of occlude the trachea. So airway obstructions are very common, and they're very prone to it, especially that first several months of life. All right, so again, guys, when we're born, we are like the only species on the planet that is solely dependent on somebody else. We are not self-sufficient in any way, shape, or form as a human being once we're born, right? We don't get up and immediately start walking around like an hour after birth, like a lot of the mammals and animals do. We can't go feed ourselves. We can't change our own diapers. So because of that, we're dependent on somebody else. There's a couple of things, a couple of reflexes that are hardwired in these infants and these neonates that typically go away throughout that first year of life, but especially those first few months, you can see these in the little kiddos. All right, so Moro reflex. All right, so this is going to be the startle, right? So if there's like a loud noise or they're abruptly moved, okay, they are gonna have like the jazz hands, like, holy crap, what just happened? Because in their minds, it's a threat. They're trying to embrace or brace themselves to kind of protect themselves, if you will. The palmar grasp. All right, so if you ever notice with an itty bitty baby, if their hands are kind of chilling out like this, and you can make any kind of stimulus in their palms, they instinctively will wrap around whatever is placed in their palms, because again, that's kind of a source of, hey, let me hold on to this for protection and for comfort type thing. Okay. the rooting reflex in these babies up to, you know, probably 6-ish months. If you make any kind of stimulus to one cheek, it's going to turn towards that stimulus, all right? Because what do you think that it's assuming is there? A nipple, a bottle nipple, or mom, right? Food. All right, so same thing with the sucking reflex. If we brush the baby's lips, they're immediately going to be like, oh, hey, that means food. And they're going to start sucking, like making that sucking motion with their lips and with their mouth. Okay, so these are just innately hardwired in these babies, in these neonates, typically up to the 6 to 9 month mark. Then they start to become a little more self-sufficient. They're not as, you know, they can communicate a little bit better.
I have a question.
Yeah.
Isn't there one with the foot, and if you like slide up on the bottom of their foot, their toes curl in?
Yes. Yes. We'll get to that a little bit later on because that's relevant to something else as well. But yeah. All right. Fontanelles. These are really important to know about, know why they're there, and some special considerations with them. What are fontanelles?
Place right on their skull with it, so it can come out.
Okay. So it's the fancy pants term for soft spots. If you've never been around an itty bitty newborn baby, if you have been around a newborn baby, what do they say? Hold the neck, gotta support the neck, and don't what? Don't poke their head. Okay. I mean, I don't know why that would be like your initial reaction to like, hey, let me poke your head. They are squishy, they are cute, but all right, so guys, if you come up here, we need to name this person, by the way, male or female. Every other class names them. So come up with a group name if you want to. Some previous ones have been Nicholas Ribcage, Captain Jack Marrow, Post Mabone, Pelvis Presley. All right, so you get the idea. We got a name. So we have to have a name for a mascot. But anyway, if you come up to this skeleton, if you look at the skull, it is fully formed, right? It's an entire circle, it's solid, and there's no holes in it except for that frame magnum, all right? But if you, hold on. All right, so I'll pass this around at leisure. I know we have to do the whole like contact girls and stuff. But if you notice, let me show you guys too. If you notice right here, it's almost got kind of like little squiggly lines down here through the middle, back here, right here. What does it look like these are kind of separating? Like, what do you think? What is this? Frontal bone, all right? Temporal, parietal, occipital. Guys, when we are born, our skull is not fully formed together. It's not fully fused together. All right, so I'll let you guys see that. Right? Why is that? Why do we not born with a? Why are we not born with a fully fused skull? So they can fit through mom's birth canal, literally. All right.
I was gonna say that'd be a more painful situation than what it already is.
Who you telling? All right. So yeah. All right. We have all of those 4 different plates or bones that make up our skull that we talked about yesterday. They're not together. They're not fused together because when baby comes out of mom's birth canal, it's big enough to get baby out, but there's no wiggle room, right? It's very narrow, it's small, and so the bones are not fused together, so it can kind of mold, the head of the baby can mold to the shape of mom's birth canal so it can get out without any brain injuries, right? So when baby comes out, you might see like they've got like that little pointy shaped head, or they've got just like a misformed head, because it takes a little bit of time for everything to go back to that circular motion or form and start coming together and actually growing together. All right, so those areas where those bones are not fully fused together, those are going to be called our fontanelles or soft spots. All right, why do you think they're called soft spots? What do we need to know about these things?
They're still cartilage mostly.
So not even really cartilage, right? Huh? Yeah, it's very, very spongy, and it is not well protected by an actual plate of bone. The brain is very vulnerable in these places, right? Because our skull is there to protect our brain. If we have these void areas where we're not fully fused with those bones together yet, then we can cause some serious damage. So that's why you never poke a newborn baby's head, because we do have these areas that are very vulnerable, okay? Just like spongy tissue, like a very spongy layer of bone that hasn't really grown together and hardened yet.
I remember when my daughter was born, there was an intern in there delivering her with the doctor. And they actually used forceps to pull her out. And so hers
She had a
was
real cone head.
more, aggravated, it's not the right word, but
Uh-huh.
she came out like a cone head.
Yeah.
And Saturday Night Live, right?
Yeah.
I'm looking at the time, like, what the heck, man?
Is that supposed to be like that? Is that gonna go back to normal?
Easy, it's gonna be okay.
Yeah, because sometimes guys they'll use forceps if it's a vaginal delivery and their mom's having a really hard time, or baby's too big, or not coming out like it should be. And sometimes they actually use, it sounds horrific, but like a vacuum seal. They will literally put like a really vacuum seal, like a suction cup on the baby's head, and kind of use it to
Happened with my daughter.
pull the baby out. Yeah. So it's crazy, but you do get these babies with a misshapen head. Is usually by a couple months out of mom, it starts to go back to that circular motion shape. But sometimes you do see these babies that are wearing like the helmets. That's because the bones aren't coming together like they should, and they have a very misshapen head, and those fontanelles aren't closing up. So they wear the helmet to kind of like push it in the right direction, to kind of mold it like it should. Okay. So you've got two of the biggest fontanelles that you need to be aware of. You've got your posterior fontanelle. So this is where the parietal bone and the occipital bone are starting to fuse together. We've got kind of that little hole, if you will, right there. And this is usually going to be the biggest one that causes the most problems, the anterior fontanelle. So we've got the parietal bone and the frontal bone coming together. And that one's usually going to be like right here on the top of their head.
Is that going to be like a little divot in their head?
So yeah, we'll get there in a second. Usually by that 12-month mark, usually around that 1 year, they're fully fused. We don't really have fontanelles anymore. Okay. So let's go ahead and talk about how we can utilize fontanelles as an assessment tool. Okay. Because if you've never felt a newborn baby's head, all right, if you're just very lightly kind of petting their head, sounds weird, but if you have kids, you'll do it. All right. So if you're very lightly kind of going across their head, you will feel a very slight, kind of just a little bit of a divot, and you can tell if you give very light pressure, it's kind of spongy and squishy. All right, it feels physically different. Now, how can we utilize fontanelles for an assessment tool in infants?
Like if it's
Okay, so maybe with age, okay.
like swollen or compressed.
Oh, okay. So if you are feeling the newborn's head, let's say the newborn's altered, right? They might be unconscious. Even if they're conscious, can they look at you and say, hey man, I just really don't feel good. I got a headache, or I feel lethargic. Can they communicate that way? No.
Nope.
So guys, especially with these infants, your assessment is very, very important, because they can't tell us anything, right? So if you're assessing a fontanelle, and other than that small little divot, it is very sunken in, like you do this and your hand literally makes that motion. What do you think that might tell us? What might be going on? They're significantly dehydrated, right? Because normally we have a good amount, an appropriate amount of fluid that surrounds and protects our brain. All right, if you are dehydrated, if you've got that fluid loss significantly enough to take it away from your brain supply, we're in bad territory. All right, so a sunken in fontanelle can let you know that we are in a very late stage of dehydration with that infant.
Would you detect that predominantly in the anterior or?
Yeah, guys, typically this anterior is going to be the one that we go to first for assessment. The posterior is there. We can use it, but we typically go to that top one first. All right, so sunken end fontanelle will indicate significant dehydration. Now on the other side, if you are petting that fontanelle and your hand does this, all right, it's a bulging fontanelle. What do you think that might be?
Too much fluid.
So maybe high blood pressure. What did somebody over here say?
I said probably too much fluid.
Okay, so maybe too much fluid, but yeah, so going towards there's way too much fluid, there's way too much pressure. Where? On the brain.
On the brain.
So that can indicate any type of brain bleed, any type of injury that caused a significant brain bleed, and also a couple of other conditions. But yeah, if you've got a bulging fontanelle, we've got too much pressure sitting on that brain. That's also not good. Okay. So just make sure you know what fontanelles are, why they're there, and how we can utilize them in our assessment in these kiddos.
Instructor A.
Yes.
So you said a bulge in the fontanelle was typically indicative of, did you say a brain bleed?
In some way, shape, or form, it's indicative of what we call ICP. Anybody know what that stands for? Intracranial pressure. That means for a couple of different reasons, there's way too much either blood or fluid pressing on the brain, and it's causing that significant swelling, and that's like the path of least resistance for that fluid to go out of that fontanelle, so it will be bulging. So intracranial pressure.
Okay, thank you.
Is that going to be different in infants as opposed to like adults? Like you have a very short amount of time, but like shorter for infants, is it worse?
With the ICP? Kind of yes and no, because those fontanelles kind of give us a little bit more time because it's an escape route for that pressure, right? There's a lot of pressure that's accumulating to cause it to bulge, yes, but at least it's bulging out and not pushing on the brain. With adults, we don't have that luxury, right? We've got to, unless we have like an open skull fracture or something like that. But we kind of maybe have a little bit more time because we have an exit route for that fluid versus with adults, it's self-contained. So yeah, we'll get to that in trauma, but good question. All right, so guys, with this, go over this in your book. I'm gonna go over it just a little bit. For those of you who have kids, you'll better understand this because you experience it in real time in real life. This is an approximate, I can't stress that enough, an approximate timeline for how these infants should be developing, okay? Because again, we can't go up to a 3-month-old and say, hey, do you know your name? Do you know where you are? Can you tell me what happened, right? Because we're not gonna get anything from that, all right? So these are gonna be kind of what we call physical and mental milestones that around these ages, we should be expecting or we should be seeing this type of maturity with both the brain and the body, okay? So guys, when they're born, their vision is very, very restricted. They can only see like maybe a foot in front of them. All right, so if you're pretty far away, they're not really gonna be able to like track you with their eyes. What does that mean, track you? Follow you, right? If I walk in the room and you're conscious and you're alert and you look at me, if I like juke to the left, what are you gonna do? You're gonna look to the left. You're gonna follow me. You're alert, aware of my presence, and you're following me with your eyes. Okay, that's what that means. So around the age of 2 months, they will be able to, if you have something in front of them, like kind of play, follow the bouncy ball, if you will, should be able to do that. Okay. 3 months, they should start having some smiles and some frowns. They're going to start grabbing at things and immediately pulling it to their mouth. Guys, this doesn't go away for a very long time. It is just an instinct for these kids. Everything they see, I don't care what it is, good or bad, this is how we start to see some foreign body obstructions in the infant's airway, accidental ingestions of like poisons and chemicals. Everything goes to their mouth. They're like, hey, this is cool, this is new, it's a really cool color. I wonder what it tastes like. Okay, so around the 3-month mark, they start pulling it to the mouth, and they start getting curious, and they have that physical ability, and we start to see some problems if they get into the wrong stuff. Okay, 4 months, they start like physically can like reach out for people, for objects. 5 months, we start to get some recognition. Hey, you're familiar. Hey, you're a sense of comfort. And hey, I don't know you. They're starting to get a little leery of people who are not constantly around them. Around 6 months, we start to see some teeth come in. Guys, a lot of first-time parents aren't aware of all of the havoc that these itty-bitty baby teeth can wreak. They can cause fevers, low-grade fevers. They can cause diarrhea. They cause excessive drooling. They cause the baby to just be very irritable because it doesn't feel good, right? That's a tooth poking through, literally coming through the gum. And it's not a pleasant sensation. So there's a bunch of other things that can happen, or like signs and symptoms of teething. So just be aware of that. They start to kind of babble at 6 months. So they might start saying like ba, 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 or, you know, da, 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 or just making noises. Mood swings, that never goes away. I have a 3.5-year-old, it's still there. 8 months, start to be able to kind of sit up by themselves. All right, up until like at least that 6-month mark, all they do is lay on their back. All right, if they're sitting up, they have to be like in a supported, secured seat, because if you sit them up, they'll just fall over. All right, so their muscles are starting to develop, they're starting to get stronger, they start to sit up on their own. They start to have that, their mind is blown, because 1 second mom's here and talking to them and laughing at them, and then she goes away. She literally, she goes away forever when you do this, but then, oh my gosh, there she is again. It's hilarious. And they're like, whoa, how did that happen? 9 months, they start to pull up on stuff. Okay, so maybe around the 9-month mark, we also might just start to see them crawl. All right, might start out with like kind of an army crawl, but eventually they'll get them on their knees and their hands. Also here, they start to, if their muscles are strong enough, like say they're crawling around and they're in the living room, they come up to the couch, they can hold the top of the couch and start to stand up. They'll be supported by that couch. They won't really be able to stand up by their own, but they can start to pull up their weight and say, oh, hey, these are what legs are for, type thing. Again, we see some trauma in this age group, because they don't know what's like a solid object that can hold their weight or secure their weight or won't topple over. So we start to see kind of falls for that. Also around the 4-ish, 5-ish month mark, they start to roll over on their belly. All right, up until then, you lay them on their back and that's where they stay. They don't move. They're just there for the longest time because they don't have that muscle strength to physically roll over or change position, right? A lot of parents find out that their kids can do this the hard way, right? Because they're used to being able just to lay their kid on the couch and, hey, stay there. I got to go, you know, got to go pee or got to go, you know, do something. And then they hear a thud and baby falls off couch, or, you know, whatever it is, because they weren't aware that they could roll over just yet. So we start to see some trauma in that range too.
I had to take my daughter to like a pediatric, like the emergency room, because I was in the shower and all of a sudden my wife bursts in just bawling because we have a tall bed and with my daughter there, and she rolled off. And from my long ago medic army days, I was like, okay, a fall of 8 feet potentially hurt somebody. So
That's like 25 feet.
You know, and like, so yeah,
Yeah,
she was fine. They're sturdier than you think.
They are very resilient. They're a lot more durable than you would imagine.
I remember when my son was born, the doctor pulled out, and I was really nervous. And he said, Sean, it's going to be okay.
Yeah, we don't do that anymore.
Yeah.
But yeah, they can handle it. So around this age, they start to know what their name is, right? So if you say, you know, Wesley, they're like, okay, that's me. Who's talking to me, right? Around 11 to 12 months, they are starting to walk and getting into absolutely everything. All right, guys, again, these are approximate ages, right? If the child is not walking at exactly 12 months, it doesn't mean that we have like a physical or mental disability, right? Now, if we have a child who is 2 years old and not yet walking, okay, we might have some concern there. But just know these approximate milestones, they are not set in stone. You know, they could walk way early. You know, my mom said I was walking at 9 months. You know, my son literally walked on his first birthday. But it varies. Okay, so just don't consider any type of mental or physical disability or delay unless we are significantly past that mark. Okay, does that make sense to everybody?
Yeah, these are unique.
All right, crying. I do a lot of it, right, guys? Particularly in this infant stage. We're talking about, you know, up to a year. If you don't have kids, you're not really going to fully understand what I'm about to talk about, but you've got to trust me that it is a thing, okay? If you have a responsible caregiver, and guys, when I say caregiver, I don't always want to assume that it's always going to be mom, because mom might not be caregiver, mom might not be in the picture, all right? So it might be mom, it might be dad, it might be grandma, it might be cousin, I don't care who it is, but whoever is like attentively raising this child, if they're a responsible and an attentive caregiver, they are going to know what different cries mean, okay? Different cries have different pitches, different tones, different senses of urgency. It sounds crazy, but they mean different things. I can be across the house, and if I hear one of my kids crying, I immediately know, oh, they're just crying because they're hungry. That's usually my 10-month-old. He's always hungry, all right? They're crying because they're tired, or they're frustrated that they didn't get their way, or they're crying because they're mad. Or if I hear that cry and I'm like, oh, no, that's a hurt cry, and I immediately go see what's wrong, okay? Different cries mean different things. So if you come up on scene and you've got a frazzled mom or caregiver and they're giving you their kid, and they're like, I don't know what this cry means. I've never heard them act like this before. This is different. Don't look at them like they have 3 heads and they're crazy. Take that with, you know, legitimacy. That really does mean something, okay? So that's the only way that they can communicate. Guys, if, again, they're hungry, they cry, right? If they're hurt, they cry. If they're sitting in a poo or pee diaper for too long, they cry because it doesn't feel good to them. If they're cold, if they're hot, that's their only method of communication, and the parents get really attuned to what these different cries mean. So they're pretty good at kind of gauging how that baby is communicating, okay? So psychosocial changes. So guys, this is where we start to see that comfort zone, right? That baby, whoever is raising that baby, that person's going to be a sense of comfort to the baby. Eventually, usually around that 9-ish, 12-month mark, we start to see that separation anxiety, right? Because they can't comprehend just yet that if mom hands over kid for baby or for daycare or for, you know, whatever reason, in their brain, mom is literally gone forever. Mom has abandoned me. She's never coming back. I don't know these people, and this is forever going to be my new life, right? That's literally their mindset. Their world as they know it is over, okay? They don't know that mom's going to come back 6 hours later because she had to go to work, type thing. So we start to see that separation anxiety. Mom's a sense of comfort. Don't leave me here. I don't think you're coming back. I don't want to stay with a stranger. I don't know them. They don't make me happy, type thing, okay? Guys, be aware of this. This can happen at different ages, right? My 3-year-old, it wasn't until like he was 1.5 years old that he cared that he was ever separated from me, right? He was cool as a cucumber going to hang out with my mom or going to hang out with my friend if I had to go do something. Like that separation anxiety didn't develop until later on. Sometimes it can be delayed. And I'm not saying that if that separation anxiety isn't there, that it is always a red flag. But if we're seeing, maybe we're coming on scene and us dressed in our uniform, coming from this flashy, scary truck, if we seem more like a sense of comfort than the child's caregiver, what are some things we might need to think about? Maybe some type of abuse, maybe some type of neglect, right? But guys, just because there is a thing where, you know, parents and children never really form that bond. Sometimes it just happens. So don't assume that just because they don't care about being away from their caregiver, especially if they're hurt or sick, that it's always abuse or neglect, but it's something to think about, right? Because like we said yesterday, if that kid is hurt, if that kid is sick, who do they want? Mama.
Caregiver.
All right, they are going to be attached like Velcro to them. So take a step back. If some other things aren't really adding up, or you're noticing some other things that you're not okay with, we might consider that there could possibly be some abuse or neglect going on. Okay? Possibly, yeah. Depending on the rest of your assessment, then we could maybe think there could possibly be a developmental, a mental delay. Okay. All right, toddlers. The second that they turn 1 year old to 3 year old, that is the toddler range. All right, whoever said terrible twos were the worst, lie. Just wait. After they turn 3, it's 1,000 times worse. I coined the term that they're a three-nager because they have such an attitude. All right, so this is my little boy. This was like 1.5 years ago, but that's Walker. That's my oldest. Their vital signs start coming up a little bit towards that normal range. Guys, too, we didn't talk about temperature for these neonates, but these younger kids, typically up into the age of like a school, maybe school age, their temperature runs a little bit higher normally. Okay, why do you think that is? Maybe hormones, growth faster. Guys, because remember, their weight and their height, it's literally on a daily basis, they get bigger and bigger and bigger. They're growing at an alarming rate. All right, so a process of that growing of the skins and the organs and the cells and the tissues and all that stuff, again, byproduct of movement is heat. All of that cellular activity brings their internal temperature up just slightly, okay? If you call a doctor's office for a child, they will tell you, don't even bring them in. We don't even consider that the kid has any kind of fever until it gets above 100.4. Okay, so they run about 1 degree higher than we do as adults. So keep that in mind if you're saying that, like the kid has a fever or you take a temperature, it could be within normal range for them if it's about 1 degree or so higher than that 98.6. Because if you didn't know, adults, our normal temperature range is around 98.6. Okay. So their pulse is starting to come down a little bit. Their respiratory rate starts to come down a little bit. Their blood pressure starts to come up. Because guys, their blood pressure when they're first born as a neonate and throughout that infancy stage can be around a 60 systolic, right? Literally half of what a normal adult's is. So everything's coming up, everything's regulating. Then we move from 3 to 6. We go into the preschool age, okay? Again, heart rate's coming down, respiratory rate's coming down, blood pressure is about the same, but it's still coming up, all right? Again, guys, they call toddlers a toddler for a reason. Why do you think they're called?
No idea.
Okay, so they don't have balance, right? They're just, especially around that first year of life, they're just starting to learn how to walk. So they literally, like, when they're walking, they toddle around like this. They fall over a lot. They still have those really big heads. So they're top heavy, right? Literally, if they're like walking around and they lose their balance, you're like, oh no, here we go again. All right. So we do start to see increased like trauma. They're walking around. They don't have like that really strong muscular control yet. So they fall down. They run into stuff. They start getting the boo-boos on their their knees and their legs and all that stuff. So that's why they're called toddlers, because they do exactly that. All right. So this term passive immunity, what is that? Okay, from mom, right? Especially if mom is breastfeeding, whatever immunities, whatever antibodies mom has in her body is created and manifests in that breast milk. Okay, so that the babies who are breastfeeding start to get some of the antibodies and the acquired immunity from mom through that breast milk. Typically around the preschool age, we don't see breast milk or breastfeeding continue, and then they start to say, okay, I'm not really getting it from mom anymore, so now I'm going to start developing my own immunity. Okay. You don't get immunity to something unless you're exposed to it, right? So they start to maybe go into daycare, or they start to maybe go to preschool, or they, start to just be around more people. This is why you always see like the preschools and the daycares, all the kids have like snotty noses, right? That term like snot-nosed brat comes from this age range, right? Because they're getting around these kids in these close quarters. They don't know about hand hygiene yet, right? They don't know, let's wash our hands. Oh, we're trying to teach my son. He's pretty good at it. Hey, I should cover my mouth when I sneeze or I cough. Or achoo, I just sneezed on this dinosaur. Hey, you want to play with it? Yeah, let's share. All right, so these germs are just spreading and spreading around. They get exposed to these bacteria and these viruses and these bugs, maybe for the first time. They start to develop their own immunities. All right, so another average milestone we need to keep in mind is going to be potty training. Okay, typically this is around the 2-year mark. Okay. My son was a freaking champ with it. He was potty trained at the 2-year mark, like almost exactly to a T. But then my niece, they're 3 months apart. She's 3.5 and she's still not completely potty trained. Okay. So sometimes they potty train earlier than 2. It just depends on, how committed you are to trying to get this done or how motivated they are. We use hey, you're going to be a big brother. You need to be a big boy now. And so you need to go potty in the big boy toilet so you don't have to wear diapers when brother wears diapers. He was like,
I would try that with my daughter. She just laughs.
wipe my bottom, sir. You peasant. Yeah. So again, if we're over that 2-year mark, then it's okay. I'm trying to urge my brother to be like, hey, you should try this because, she's 3.5 and still in pulse. But guys, if we get to like a year 5, year 6, and we're still in diapers, what are some things that we need to start considering? Okay, so we might have a developmental delay.
Neglect.
Possibly neglect, right? Because these kids, the whole nature versus nurture, guys, until you have kids, you don't understand like how much weight that holds. All right. These kids, unless they are being positively enforced at home and have somebody who really cares and is attentive and trying to work with them to get them potty trained or to get them to that milestone, they don't know any better, right? They don't have like an innate drive to be like, oh, this is nice. I just pee whenever I feel like it and somebody cleans me up. Hey, what a life, right? They don't know that they're too old to be in diapers yet. They don't know that they need to be potty training. So if we don't have anybody that's at home really working with them and really caring about it, then that might also be a reason that we're significantly delayed past that milestone. Okay. So again, these are approximate milestones. Just make sure that if they are 2.5 and they're still in pull-ups, oh, I'm calling DFACs on you. Or, nope, their brain's not working completely. Take a step back, look at everything else, okay? Start to learn how to talk, actually use like sentences. I have full-blown conversations with my 3-year-old, and it's still just crazy. Like, we were talking yesterday or the other day outside. We just, my husband and I were like, hey, what's your favorite food movie? Like, just see what he says. We're like, what's your favorite animal? He goes, a seahorse. I'm like, dude, how do you even know what a seahorse is? I don't even think I would use that word in front of you, right? So they surprise you with the things that they know. Again, it's nature versus nurture thing. They start to make noises, but if you're not having conversations with them, right, and introducing new words or telling them what things mean, they're not going to pick up on it. So if we're again at that 4, 5, 6 year mark and we're not speaking, again, consider possibly a delay, possibly some neglect. Again, they start to talk full sentences. They are very social at this point, cause and effect. So my 3-year-old's just now starting to let this sink in. Technically, he's 3.5. That if we say no, and if I have to tell you again, you're going to timeout, he understands that, oh crap, mom means it, right? If I do this, if I push my brother over or smack him in the head, then that means I'm going to get in trouble and I'm going to go to timeout, right? They start to understand that whole, okay, I did that last time and I got in trouble, so I'm not going to do it again. Whatever. Yeah, maybe. The gender differences, guys, this is still super in play. If you go to Target or if you go to Walmart and you walk down the Barbie aisle, what color is it? Pink, everywhere. All right, if you walk down the Hot Wheels aisle, what color is it? Blue and orange and green, everywhere. So they start to understand and notice that, my son's doing it now. Say, Mama, girls can't do this. Girls aren't strong enough to do this. Only boys can. I'm like, what? So they start to understand differences in the gender roles. Elsa is for girls. He loves Frozen. But, Elsa's for girls and Kristoff is for boys. They start to pick up on that. Okay.
That's good. That's a cultural thing too.
Yeah, exactly. So moving into the school age children, all right, this is going to be from the 6 to 12 year range. This is where we really start seeing that the drop in the pulse, the respiratory rate coming down, that blood pressure really coming up, starting to get almost to that normal adult range. Okay. So how they're really going to look, how they're really going to, I guess, whatever genes they take, if they're gonna look like mom or dad or whatever like that, start to really be set in stone. They are significantly growing as well. They start to get their permanent teeth. I think there's a question on the quiz about something relating to this, and I can't talk about it because you guys haven't taken it yet. I got to get used to that. Brain activity increases in both hemispheres. What does that mean? We have hemispheres in our brain. A left and a right.
The left and the right brain.
So left side of the brain and right side of the brain. Okay, they've done all sorts of studies, and they have come to show that if you are more active, the left side of your brain is more active. What kind of trait do you have, according to these studies? So logical thinking. So the way I remembered it, left is logic. So L. That means that you like details, you like numbers, you're very attentive to making sure things go by procedure, you like things that are organized. All right, that right side of the brain is you might have a lot more creative traits, right? You might be artistic, you might be able to play music, you might just have a very imaginative view of things. Right, so both of these hemispheres really start sparking up in this age to really define, what's going to be their character traits, what they're going to be to thrive in, sports or music or stuff like that. All right, we start to see that they are maybe at school and then their ideas or their opinions or their activities might start to be swayed by friends, by what other people are thinking is cool or something like that. Self-esteem really starts to come into play here. Guys, I highly recommend that you get one of these, what we call badge buddies. Okay, again, we've got to know these different vital ranges for these different ages. Okay, typically we don't see a ton of pediatric patients in a pre-hospital setting. Okay, unless they have like significant medical problems or it's just an unexpected trauma injury, we don't really deal with a lot of pediatric patients. So it is easy to kind of forget these vital sign ranges if you're not seeing these children on a daily basis. All right, adults we see day in and day out. All right, there's no reason that you should not be aware of the adult vital sign ranges just based on pure repetition. Okay, so this is like $3 on Amazon. I'm sure they probably sell it other places. I really should be like sponsored by Amazon because I've told you guys to give them so much money. But you can see it's got like a little punch out. It goes in your badge reel, so you can have quick access to say, oh, this is a 3-year-old, this is the heart rate, is this normal for them? Let me check. Okay, so it's got the average weight, respiratory rate, heart rate, a systolic blood pressure, and even on the back, it's got the approximate milestones that we should expect for that age. Okay, highly recommend that you get it. I may or may not have one myself. All right, but that's a really good resource for you guys to use. All right, so the adolescent years. Oh boy.
Actually, I thought those were a lot more fun than the other two.
Really? I love, like, I want to scream at my 3-year-old sometimes, but I love this age. It's so fun.
My daughter was a risky sport.
So the 12 to 18 year range, okay, this is where we move into the adolescent stage. Pretty much we are almost there to the vital sign ranges, okay, 60 to 100, 12 to 20, 90 to 110 for that blood pressure. Again, guys, that blood pressure is going to fluctuate with the size of the kid, all right? If you've got a 10-year-old who you go up and you be like, hey, sir, you want to buy a beer? Yeah, sure. You're like, oh, wait, you're not 21? You're 10? Because they're a massive kid.
Sorry, I couldn't quite hear you. Could you please repeat what you said?
Not crazy at all.
I'm sorry, what did she say?
That was something.
The government would like to know.
Yeah, the government would like to know. So, yeah, guys, it depends on the size of the child, right? If you have an abnormally large 10-year-old, their blood pressure is going to be what? Higher. Bigger surface area. That left ventricle has to pump harder to create more pressure to make sure that extra surface area is perfused. All right. So again, these are approximate vital signs. So we enter the adolescent stage when we start hitting really that like sexual maturity. Okay, that puberty stage. Guys, typically girls go through puberty before guys do. Typically they're done with that whole puberty stage by 16, guys by 18. What do we consider puberty for females? Okay, so they start to receive their menstrual cycle, all right? Because I'm not like organic, holistic, or anything like that, trust me. But girls these days are reaching that sexual maturity and receiving their menstrual period earlier and earlier and earlier. It is mind-blowing that I had to, at one point, on one call, ask a 10-year-old if she was sexually active because she had started her period and it was possible that she'd be pregnant. Okay, a lot of it is there's a lot more like hormones that are injected in, you know, foods and the milks and stuff like that. I eat all of it. I'm not saying don't do it, but they're starting earlier and earlier and earlier. So we might be outside of this age range, but what might be something that prompts you to ask, especially female patients, if they have received their period. What might we see?
Development of secondary sexual characteristics
Yeah,
like breasts.
so breast development, right? Maybe like full blown underarm hair, any type of, the acne where the hormones are starting to really kick in. So guys, that is a valid and it's an appropriate question if that's present. Obviously, we need to keep in mind the privacy and the modesty of these patients, and we'll talk about that in a couple slides. But yeah, if in females, if we see any like developed breasts or underarm hair or anything like that, that's a question we have to ask. And it might be mind-blowing, but it's something we have to know about and consider, because if you got a 12 or 13-year-old female patient who's complaining of just being tired and maybe abdominal pain, if she started her period and she's sexually active, it is fair game that could be some early signs of pregnancy. Okay, we can't let that flip our mind because that's part of our assessment.
You asked that question specifically related to the case of point. So you're showing up and fall off the bike and busting up your leg.
Yeah, not if they like fall and break their ankle. Hey, we started your period, you're sexually active. That's not relevant. But if it's anything that could be relevant to maybe like a sexually transmitted disease or pregnancy or anything along those lines, we have to ask. Yeah. Voices start to change. The little boys' voices start to drop a couple octaves. All right, we see the acne from the hormones. Privacy becomes an issue, right? When you go through those teenage years, mom and dad are dumb. They don't, I'm not a kid anymore. Leave me alone. Let me do my own thing. All right, what do we need to keep in mind with this? When it comes to maybe talking to our patient or assessing our patient or anything like that. Okay, we don't want to embarrass them, right? Especially if we're around friends or anything like that. Try to get them in a private, like, let's get in the back of the truck, just me and you talk. But these guys are still what?
Minors.
Minors.
Separation parents.
Right? So guys, if you've got like a helicopter parent, right? Because we talked about that involuntary consent. We've got a 15-year-old kid, his stomach hurts. He's A&O times 4. I don't want to go to the hospital. My mom's a hypochondriac, but mom is insistent. No, he needs to go. WebMD told me he's got cancer, whatever it is. All right. Technically, I have to tell that 10-year-old, dude, sorry, I know you don't want to go, but mom makes decisions for you, and she's telling us we're going to the hospital. Right? So you might have a patient who's got maybe like a helicopter parent, and they will not leave their side, and they're just like standing there like listening to every question that you ask and all that stuff. Guys, especially if it has anything to do with the S word, like with sexual activity, if it's possibly like an STD, or it's possibly that this female pregnant could be patient. Pregnant. I need more coffee. Do you think that they are going to give you honest answers about that stuff in front of their parents? No. All right. Now, can we say, well, I have to, Mom, you cannot go with us. Mom, I'm ordering you to walk away right now. Technically, we can't. Right? So what are some things that we can do? Distract mom. Distract dad. Hey, yeah, he's really complaining of this. Can you go? He says that he wants you to go get his blank. All right. So typically, if it's a helicopter parent, they're going to be like, oh, yeah, I can help. I'll go do that. Hey, dude, we've got 60 seconds. I need you to give me honest answers. No judgment. I don't care, but it's going to change the medicine or the treatment that you may or may not need. Are you sexually active? Or, could this be, this, or the female patient? Are you sexually active, unprotected sex, any chance you could be pregnant? All right. Now, oh yeah. So guys, utilize your partner, right? Whoever's going to be like the patient care provider for that particular call, you're with that patient, have your partner be like, hey mom, I just need to ask you a few questions over here. I need to get like your insurance information. I need to get, any medical history. So we're, kind of distracting, kind of tricking, whatever.
Does it never work to just nicely ask the parent to use privacy?
Because then they're like, well, What are you gonna say that?
Yeah, no, I feel that, I understand that.
Yeah,
I just
Um,
worried about the work.
so
Even in
we,
my situation, if somebody asked me that, it'd be like, well, you can go yourself.
Yeah.
I'm not standing right
yeah. I mean, because guys, it could be that the parents overbearing or the parents, seeing way too many 5 o'clock news stories where bad things happen to kid. I mean, it's a parent's brain is a very interesting place. But typically we need to give some distraction to say, hey, tell me what's really going on type thing. Okay. Now, what if a parent comes back from getting that glass of water or whatever and is demanding, well, you got to tell me what you said, what's happening, what is going on, tell me what's wrong with my daughter. What if in that 60 to 90-second window the daughter did confide in me, yeah, I haven't had my period in a couple months, I think I'm pregnant. What do I do with that? Okay, because I got to think about HIPAA, right? Patient privacy, but they're a minor, right? So what can I do? Because do I just want to turn around and be like, yeah, Stacy over here just told me she's knocked up, so that's what's going on with your daughter. No, right? I don't want to do that because that's going to completely destroy that rapport, that relationship that I have with that patient. So the best tactic I found, you're just going to omit some information. You're not just going to straight up like, oh no, she's not pregnant. No, all right? Don't say that because we don't want to just straight up all-face lie. But you can say, well, not really sure, right? Vital signs look okay. There's not a whole lot of tests I can do in the back of the truck. So we'll get you to the hospital. They can do more tests there. They can give you more answers there.
Like just throw a bunch of numbers out.
I mean, you can tell like legit vital signs, right?
Then they're gonna do it.
Yeah. But if you say, from what I can see, she's stable. I don't see anything that's concerning, but I can't do everything in here in the back of my truck. You can get more answers. They'll be able to tell you more. They'll be able to do more tests at the hospital, right? Because am I lying? Do I have a pregnancy test in the back of the truck?
You're being discerning.
I don't. I can't 100% confirm that she is pregnant, right? Or, that this is Timmy and he's got an STD because he's sexually active. I can't 100% confirm that in the back of my truck. So I'm not lying to the parent, but I'm still trying to keep that relationship with my patients intact, and they can have conversations when lab results come back at the hospital, right? Because that's not really it's not our job to be Maury and be like that family therapist there.
I mean, would you tell that patient, so you're with that patient, right, to be part of that dialogue, about that, that you need to actually get some test, and you recognize that from being this.
I mean, yeah, you could have if you're on that level with your patient, just be like, hey man, I'm gonna keep this a secret between us, but it's gonna come out eventually. Just let you know. That's fine. But yeah, we don't have to be the bad guy in that situation. We are not gonna lie, but we're just not gonna tell the whole truth. Okay. So guys, again with privacy too, if it is any reason that we are needing to fully expose a patient, cut all of their clothes off, we do that in significant trauma injuries. If a patient's unconscious, unresponsive, we have to fully expose them to see exactly what's going on. If this is a teenager, they are probably going to be very hesitant to that. If you're fully exposing them, they're very kind of modest at that age. So just let them know, hey, we're going to keep you covered up with a blanket, but we have to do this to take care of you. Again, we're explaining why we're doing what we're doing, but just expect that kind of whoa, I don't know, I'm not okay with this. But if it's absolutely necessary to do, then, we need to do it. Oh, the curiosities, right? Most adolescents start to become curious about drinking, about drugs, about smoking. Again, with that sexual, these new kind of feelings, and be like, oh, what's going on here? Let's explore this. We start to see, again, possibly the pregnancies, the STDs, and also the inhibitions that are lost when it comes to drugs and drinking, right? What else kind of mindset do we have that we start to see increase maybe trauma injuries in teenagers.
Risk-taking.
Risk-taking. Why?
Do stupid shit to impress a girl.
Okay, hey, y'all, watch this, right? To impress a girl. What else? Why else?
No concept.
Guys, you are invincible as a teenager. All right. You understand the finality that death does exist, right? If somebody dies, they're not coming back, but it can't happen to you. Dude, you're 16, 17, 18. You're in the prime of your life. You're the star football player. All right. And nothing like that's going to happen to me. All right. So just that kind of invincible Superman mentality, especially in males, we start to see, you know, I don't need a seatbelt. I'm going to wear a seatbelt. I don't need to wear a helmet. I don't need to drive the speed limit. I can drive as fast as I can type thing. Hey, y'all, watch this. Let me impress, you know, Tina over there. So we start to see some increased trauma because of that mentality, because of this age range. It might be fueled by that underage drinking. You know, you don't really have a good grasp on what's your cap when it comes to drinking, like in high school. I wouldn't know. But you know, the older you get, the more that like less taboo the drinking thing is. You're like, okay, I'm good. I'll have a couple drinks and I'm good. I don't have to chug punch or like, you know, Natty Light or anything like that. So yeah. Guys, this suicide and depression, again, high school's a rough place, right? If you're not in a good clique, if you're not popular, people are mean. But unfortunately, this is happening again, younger and younger. All right. My husband ran an 11-year-old who killed himself. 11. As there's been stories, I mean, I haven't had personal interaction with it, but there's been 9-year-olds who have committed suicide because they're being bullied. That breaks my heart to a million pieces, right? So all of this, you know, I sound like a grandma on technology these days, but seriously, like the social media, all of that stuff, this pressure to look a certain way or to act a certain way or to be a certain way starts younger and younger and younger. All right, like these 10-year-olds have Facebooks and Snapchats and whatever else there is out there. So if you've got a middle schooler or guess even elementary schooler who's talking to you and just seems very like, you know, removed from the their life, they have these depression tendencies, they're sad or they just don't care, don't brush it under the rug. Don't think, oh dude, you have no idea how hard life is. You're just, you know, you were picked last for the dodgeball team or whatever. Like you're just trying to get attention. The one in particular that my husband ran on himself. Yeah. So guys, it might be that they don't really know how to handle these feelings and they don't really want to go through with harming themselves and they're just saying these things. It might be that situation, but don't just assume. All right. Unfortunately, we have to take all of this stuff seriously. All right. Because if you brush it under the rug and you just convey during that verbal report, you know, oh, it's nothing. You just had like a hard day at school. You know, the proper care and the continuity of care might not get followed through and they might actually go through with their plan.
So
All right.
how do you document that? You can talk about what you document and not document, so if you observe some behaviors or comments related to us.
Mhm.
You put that in your report, or do you
If it's factual, if it's objective, all right? So if I'm talking to this patient and he is literally telling me these responses, yeah, man, I just don't care anymore, you know, whatever it might be, I will chart patient stated, you know, exactly what he said. I can't go in my chart and say, you know, patient appeared to be depressed, because what is that? It's opinion, it's subjective. But everything factually and objectively that your patient says or that you notice, put it in your chart. And then again, guys, when we give that verbal report, that's kind of more so like off the record stuff. We can say, hey man, he was saying this, I really think he could be depressed. or I think he's getting bullied at school or whatever. We can talk to the nurse like that. It just can't go in the chart.
Are you ever able to connect the dots between injuries and maybe bullying in school and stuff?
Maybe not so much bullying, but abuse, definitely. Yeah. Guys, is everyone okay with the definition of what objective versus subjective is? I know I've been throwing those terms out. I don't know if I actually like went over the definition. You're not okay with it? I did. Okay, so I'm gonna go over the definition, all right, really quickly. So objective, we've talked about, that is factual. That is straight up something that you can measure, and it's there. There's nothing that's gonna change that this is what happened, right? So imagine something objective. You guys are gonna have medical knowledge at the end of this course, right? So you have got to type these things in your chart objectively. Use the gauge of, if I pulled Joe Schmo off the street and put him in that scene, Joe Schmo, who has no medical knowledge whatsoever, he doesn't know how to diagnose or what these things might mean. Joe Schmo could see, yes, there was a needle sticking out of that person's arm. Or yes, the patient was stumbling around and couldn't talk appropriately. Or yes, if I showed him the blood pressure cuff, he could see what the numbers were, right? That's objective, all right? So things like vital signs, that's objective. I'm not making an assumption. I'm physically measuring a blood pressure, a heart rate, a blood glucose level, right? Because a big one too comes with like intoxication and drug use, right? Can you factually say your patient was drunk?
I was gonna ask you about that actually.
No, and I really should have talked about this in the documentation chapter, but we didn't, so we're taking a little sidebar here. But can you say patient was drunk? No. Do I have a breathalyzer in the back of my truck that I can run and objectively say patient's blood alcohol content was blank? No, that's not my job. I'm not a cop, right? So how can I chart, guys? Has anybody never been around a drunk person ever? No? Okay, good for you. So this might be a little bit harder for you, but for the most part, if you've ever been around somebody that's drunk, how do they act? Okay, so they can act like an idiot.
Mine is some are funny, some are, you know.
Okay, so
What have they been drinking? What time of night is it?
It's really on a case by case basis, honestly, because I've been around different types of drunks.
Right. So typically
really
there are
depends.
like those 4 categories of drunks, right? You get the happy drunks. Everybody's their friend, you know, they're just singing and all of that fun stuff. They're happy, they're fun to be around, okay? You get the emotional drunks, the ones who just, the heart, just the gates open and they're crying and they're confessing their love, or, you know, I love you, man, type thing. You get the angry drunks, right, who just want to fight, or, hey, man, you looking at me, what's your problem, dude? No, dude, I was literally just like grabbing a beer. Good.
The worst kind. I said those are usually the worst ones.
Oh, yeah. And then you get just the sleepy drunks, right? They just kind of pass out. They just kind of zone out. There is kind of that 5th category that one of my students brought up to me that's kind of sprinkled throughout, the promiscuous drinkers. All right, but if we're to the point where we are intoxicated, I don't care what category you fall in with that drunk. If you are drunk, what are some physical things that happen?
Lack
Okay.
of balance.
So your balance is a little bit off. You're not able to articulate very well. We get some of that slurred speech. No, it increases. Thank you. So maybe you've got, like, you know, the bloodshot eyes, that type of thing. Okay. The glazed over eyes. You get the flush, the red. See, yeah.
You also lose focus.
Okay, yeah. So, but can I bring Joe Schmo off the street for somebody who is absolutely drunk, and Joe Schmo can also see that they have an unsteady gait? Can Joe Schmo also understand that they have slurred speech? Can Joe Schmo also see the redness in the eyes, right? That's how you're going to chart patient appeared or patient presented with unsteady gait, slurred speech, redness to the eyes. Okay. If I walk on scene, again, if I see a drug needle sticking out of somebody's arm, can Joe Schmo see that as well? All right. If I walk on scene and there are 17 empty beer cans around my patient, Joe can see that as well, right? I'm not insinuating that my patient drank all 17 of those beers, but I objectively saw on my scene 17 beer cans. I'm not assuming that my patient drank it, but Joe can also see those 17 beer cans. It's a fact that they were on my scene.
Okay, Professor, I got a quick question too. All right, so I understand that when you're writing out your report that you're giving indication of the environment, right? So let's just say that there's nothing in the environment that gives you indication that they're under any kind of substance. But if in your report you say, like say they do have the unbalanced, the poor balance, the bloodshot eyes, or whatever the case may be, if you just generally say they appear to be under some kind of substance,
Nope.
you can't say it like that. It has to be specific.
You have to say exactly what signs and symptoms you observed.
Okay, I just want to make sure because
Yeah.
I know sometimes it's thought that general statements can come off as non-opinionated, but I just wanted to kind of put that out there.
No.
So at all times it has to be specific instances, like they have this going on, they have that going on, they have this going on, and so on and so forth.
Because let's say it's like a DUI case, right? Somebody was drinking and driving, they killed somebody, it goes to court. All right, so you as a patient care provider, it has to be objective. They presented with these medical signs and symptoms. Unsteady gait, slurred speech, bloodshot eyes, whatever it might be. It's gonna be up to like the lawyers who bring in the medical consultants to the case to say, well, what do these signs and symptoms mean? If somebody who's drunk, would they present with these signs and symptoms? That's not our job, right? We're charting objectively what we see.
Okay, yeah, I just wanted to make sure because sometimes general statements can be mistaken as being objective when it's really not. So that's why I was, wanting to put that out there as a question.
Now, what is one thing that we can do and can put in our chart?
Quotations.
Quotes. Now, guys, you got to be careful because we're not typing a police report, right? I don't want to get like witness statements or, bystander stated, oh, I saw this or I saw that. But if your patient straight up tells you, dude, I am drunk off my butt, or man, I am high, I love ecstasy. Patient presented with unsteady gait, slurred speech, whatever that objective finding is, and then patient stated, quote, I am drunk off my butt, period. I love ecstasy, period, end quote. Okay, because if Joe was standing here next to me while the patient said it, Joe would have heard the same thing. That's objective. It goes in my chart. I am still not forming an opinion or assuming that my patient actually is drunk or on ecstasy. But a lawyer can put these puzzle pieces together that I put in my chart and go do their job. Right?
So like when you're charting like quotes like they're like policy direct quote verbatim, or if they say like something.
It needs to be as verbatim as possible if it is in quotation. Oh, you can get colorful with language too. Oh yeah. Sorry. You've got to be careful with that. You can't, so she was asking, can you document like you walked on scene and smelled alcohol? What does alcohol smell like? Right, so yeah, you have to be careful because alcohol can smell like a fruity margarita or it can smell like straight up whiskey. That can be subjective.
That actually helped me once. I was in a car accident and I was unconscious, but the guy who hit me, the ambulance driver asked him, the paramedic asked him had he been drinking, and he was like, "Yeah, I had a couple beers this morning."
Yeah, so guys, noted empty vodka bottle in the back or in passenger seat of vehicle. That's objective. I'm not saying the patient drank it, which
I hit him,
did,
but he didn't signal or anything, so it's
Yeah.
safe.
Yeah, and guys, that's another thing too. Like whatever your patient is doing, like on the ride into the hospital, that's objective too. We'll get there when we talk about pain scale because I got a real good one for that. But yeah, that's something you can chart.
Someplace smells, you like know like that you smell something like at all.
Yeah, like you just have to be careful with the alcohol, right? Because if it's like a chemical smell, you can say noted chemical smell, noted smell of urine, noted smell of feces, like whatever it is. But just you could noted smell of, I don't know. I would have to ask our lawyer. We're actually really good friends with her over here for Granny. Exactly what would be acceptable, because you could put noted smell of like ethyl alcohol, maybe like ETOH. But yeah, I'll get a definitive answer for you on that, because you can't. I mean, you could say noted smell of beer, maybe. Right. Right. Do you have a question?
It's not fun.
Okay.
One.
Yeah.
So kind of transitioning back to the teenagers thing, would you document signs of, for example, depression? And if so, how would you do that?
So yeah, so like we were talking about before, so is everybody good with objective? Like what is objective? And then subjective, guys, that's just going to be anything that can be construed as an opinion. Any assumption that you come to, any like, patient was acting stupidly. Well, what's perspective? Stupid is perspective, right? So yeah.
So we don't document.
Now you can document patient was acting erratically or inappropriate for the environment. That's fine, but like you can't do anything that would be significantly different from each person's perspective.
You just need to be as concrete as possible.
Yes. Yes. Yes.
Because anything else is, your definition of adverse crime.
Exactly. Exactly.
Okay, well,
All right, so everybody good to segue back into lifespan? All right, so coming back to your question, yeah, you can't say that patient appears to be depressed, because again, that's going to be your definition of depressed might be different from yours. If they have had a medical diagnosis of depression previously or bipolar schizophrenia, anything like that, that's objective. That will go in a different area of your chart as their medical history. But you could say patient, was crying, if they're physically crying, patient stated these things, patient was withdrawn from conversation, like if they're not really talking to you type thing. Anything that Joe off the street, if they were there during that call, they would say, yes, the patient did say that. Yes, the patient did do that. They can corroborate the same thing, can be put in there.
Okay, things like withdrawn or monocytic cancers are objective
Yes.
things for the purposes.
Yep. Okay. All right. Again, we might see some eating disorders because trying to fit into that standard mold type thing. The two biggest ones you guys are going to see are anorexia. What is that?
Don't eat anything.
You just don't eat. Okay. What complications or medical presentations might we see with anorexia?
Dehydration.
Okay, so maybe some dehydration. The blood pressure might be low because of the dehydration. Maybe low blood sugars. Maybe some electrolyte imbalances, malnutrition type thing. The other big one is bulimia. That is, you binge eat and then you make yourself throw up, so you don't actually digest and process those calories. What are some medical presentations with that? Okay, so maybe sore throat, maybe some like an eroding of the teeth or, the lining of the throat or the mouth, because what's in your stomach? Acid. If you're constantly exposing all of this soft tissue that is not used to and should not be exposed to that acid, we'll start to have some problems with the composition of the tissue. Could be, yeah. Okay. 19 to 40, here we are. We have reached the milestone of the normal vital signs, all right? So here, heart rate 100 to, or 60 to 100, 12 to 20 breaths per minute. That 120 over 80 is ideal for the blood pressure, okay? Guys, it's not until you reach the age of 25 that all of the aspects of your brain are fully matured and developed. All right. So that is why you youngsters in here who are not yet 25, you get to look forward to the day you turn 25, your car insurance goes down. Because the insurance companies have had this scientific evidence by the time you turn 25, you're not going to be making those stupid rash decisions to speed or run a red light or do anything like that. That's literally why your car insurance drops when you turn 25. Okay. At this point, usually, sometimes not with everyone, lifelong habits are solidified. If you've gotten in a routine of liking certain things or doing certain things or something like that, it's pretty much going to be there with you for the rest of your life in some capacity. You might start to settle down. You might start to get like a career-based job. You might meet somebody. You might get married. You might buy a house. Some of that doesn't come until much later in life, but we start to see that start at this age. Look at this middle adult here. He looks so suave. 41 to 60, vital signs are going to be the same. Okay. We might start to see an increase in what vital sign? Blood pressure. Right? Because if we're at the 40, 50, 60 year mark, we've got some miles on these tires, right? We've got, maybe we've been a smoker for, 20 years, maybe a drinker. We eat whatever we want. We don't exercise. That's when we start to see some of these problems with that atherosclerosis and other medical conditions that can occur and develop because of these bad habits, okay, for this extended period of time. So again, we start to see some cancer. We start to see maybe starting to lose hearing and vision. That's kind of a stretch for a 40-year-old, but it's possible. Menopause. What is menopause? Okay, so females, we no longer have a menstrual cycle, all right? We are literally born with every single egg we will ever have in our entire lives, okay? Guys, you don't have a shelf life on your reproductive system, right? You are continuously creating new sperm throughout your life, like up until like 80s.
It's actually one of the biggest theories why women sexually mature significantly quicker than men.
We have a time clock. Yeah. Once we run out of those eggs, we literally cannot conceive. We can't carry kids anymore. We're out. We've got a shelf life. All right. So when these females are running out, where they're totally out of eggs, we don't need certain hormones anymore. We don't go through certain processes anymore. So our body starts to change. That is menopause. Okay. So significant mood swings. You get those the hot flashes. You're no longer having a menstrual cycle type thing. That's what menopause is. Anywhere from 40s to 50s, women start to go through it. Could be earlier, could be later, but that's typically that target age. Okay. Diabetes and high blood pressure. So again, these start to rear their ugly heads because we've had these years of bad habits, right? Diet, exercise, all that stuff. So if you have kids, we start to see that the empty nest syndrome, right? You're used to having kids in the house, they leave, they go off to college, you don't know what to do with your life. You have a midlife crisis, go out and buy a Harley, or you're like, hell yeah, let's go to Mexico, like whatever mentality you have. But you start to get, if you have kids that go through this, you start to get kind of like a new, maybe new habits, new outlooks on life, whether good or bad. Older adults. Okay, guys, this says 61 and up, but we technically classify 65 and higher as a geriatric patient. Okay, those are going to be your elderly patients, your geriatric patients, 65 and higher. Okay, with the technology, with the medicine, life expectancy is constantly elongated. Now it's around the 78 to 80 year mark. All right, women typically live longer, but that's just case by case, I guess. Science, yeah.
No, size.
Oh, size, yeah. All right. Here we go. Guys, we spent a lot more time talking about the babies, and we're going to spend a lot more time talking about the Jerrys, all right? Because there's a lot of things that start to go wrong when we get older. So we said a blanket statement globally, what starts to happen the older we get? We start to deteriorate, right? It sounds sad and depressing because it kind of is, but it's true, right? Guys, our heart is not designed and built to last, 100 plus years. It literally every second of the day it's beating, and eventually we'll get tired. It's not going to work as well, right? Our organ systems start to kind of shut down. They too have a shelf life. So we start to see organ systems, they're not working as efficiently and effectively, and everything just starts to kind of shrivel up, if you will. Vital signs in this age group are going to depend on the overall health of the patient, okay? If they've got all of these, what we call comorbidities, what's a comorbidity? Multiple medical problems, multiple medical diagnoses, okay? So if we've got high blood pressure and we're a diabetic and we're a dialysis patient and we got high cholesterol, that's a lot, right? What do you think our blood pressure might be? A little higher than somebody who is the same age and doesn't have any of those medical problems, right? That's going to be the same in any age group, but particularly when we get to the geriatrics. Medications, all right? The big pharma, right? So how this works, is anybody on here on one or any medications? Okay. How it starts to work specifically when you get older and your body can't compensate as well. What I mean by compensate? Adjust. So maybe if my heart's not working as well as it should be, the rest of my systems can kind of pick up the slack, right? That's compensating. The older we get, we don't do that as well. All right, so let's say I've got a 75-year-old patient who is taking a hypertension medication. What is that? High blood pressure. Hypertension is high blood pressure, okay? They're taking a medication that's supposed to chemically bring down their blood pressure so it's not that high, okay? But a side effect of that high blood pressure medication is going to be, say, bradycardia, all right? Based on how that chemical works. So they have to be put on another medication to make their heart rate higher to change the side effect of that initial medication. All right, guys, it's a snowball effect. All right, so typically, thank you, sir. This is Mr. Linwood. We have dubbed him the new Corona killer. He keeps his academy squeaky clean and keeps Corona out of here. But yeah, guys, it's a snowball effect. All right. So typically, if you're on one medication, you're going to be on 3, going to be on 5, going to be on 7. Okay. So anticipate that, not just with geriatrics, maybe these middle-aged patients. Guys, when you go to pick up a patient, you say, "Hey, man, what kind of medical history do you have? What kind of medicines do you take?" Some of them will literally throw a shopping bag full of their pill bottles and be like, "Here you go." Okay. What can be a problem with geriatric patients? And this is what we call polypharmacy. What does poly mean? Many, and then pharmacy, drugs. All right, so what can be a problem with polypharmacy, especially in the geriatric? Okay, so maybe we might start getting into maybe early onset dementia, maybe some Alzheimer's. We start to get kind of forgetful the older we get, right? Because our brain, guys, literally gets smaller. Pause for 2 seconds. So yeah, maybe they might be forgetful when it comes to their medication. How might that be bad? Okay, so maybe they totally forgot that they were supposed to take their medication twice a day and they only took it once. All right, guys, once you start taking medication, your body becomes dependent on it. Your body functions because that medication is in your system. All right. If you're not taking it, your body goes into freak out mode. It's like, whoa, 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 whoa. Where is that lisinopril? I don't know how to manage this blood pressure without it. And we start to see some really bad problems if you are not taking your medication like you should.
At times you come across somebody who's good, and then they catch up. You see what I'm saying? Like, so I missed a few days. Oh my gosh.
So that's another end. So they might forget to take it. All right, and then just not take it at all. Or they took it that morning and they're like, oh, I take it this morning? I can't remember. I'm going to take 2 just in case. So they might have an unintentional overdose because they take more than they need because they can't remember they took it this morning and they, if they take it twice a day type thing. What also is another problem? What also problems do we start to see with geriatrics, the older people get with some of your senses? Okay, so your senses start to go down, right? We talked about the pain, the sense of pain. What about your visual? All right, we start to have that be compromised. How might that be a problem if they've got a ton of medication?
Body temperature, their body temperature becomes questionable too, because a lot of them will always be cold or always be hot.
Yeah, we'll get to that. But yeah, guys, a lot of these pills look the same. They might take one thinking it's another, and they take the wrong medication, right? They might read the wrong dose. They might not take the appropriate dose. All right, so a lot of things to keep in mind, especially with the geriatric population. The whole medication can be a really bad combo if they are not staying on top of making sure that everything is done correctly, if they don't have somebody like maybe caring for them. That's why you see the pill boxes. All right, have you guys ever seen them Sunday through Saturday? They will typically either get, like their child or somebody who is, not as old, I guess, and they will go ahead and lay out everything that you're supposed to take on Sunday, all these pills, it's all there. All you have to do is open it and take the pills. So there's no, discretion with wrong doses or did I take it or did I not? Okay, that's what those pill boxes are for. Cardiovascular system, what happens overall with this? Guys, the heart gets tired, right? It's been beaten literally day in and day out all their life, okay? So here's that term again, that atherosclerosis and that arteriosclerosis. Here's a bad diet, bad, physical activity, but then also we talked about the muscular component in the vessels gets hard, it can't constrict, it can't dilate, and that can lead to high blood pressure as well, okay? So typically your heart rate and therefore your total cardiac output is going to start to go down. All right. If those numbers are going down, what else do you think is going down or can? Your blood pressure. Yeah. Okay. Again, the vascular system becomes stiff. That's that arteriosclerosis. We don't replenish our blood supply as best as we once did. When I was talking about the spleen, I meant to talk about our blood. What's the typical lifespan of a red blood cell? Anybody know?
Like a week, I think.
Longer than that. Longer than that. 3 months. 3 to 4 months. Okay, so that's the lifespan of a red blood cell. Lasts about 3 to 4 months, and then we just keep making more. We don't do that as well the older we get.
Are you going to see like a decrease in the blood
possibly if we have some things that are affecting the respiration, actually getting that O2 onboarded to the blood. All right, so moving into the respiratory system. All right, the size of the airway increases. Why does this happen? Huh? So we get bigger, yeah, but typically when you are, as an adult, it doesn't really increase past the size of an adult.
Relaxation of the cartilage that initially kept it together.
Okay, so what's something that, like with the integumentary system, with the skin, we start to see the older we get? Start to get wrinkles, starts to not be as plump and as nice. All right, we start to lose that collagen that helps keep our skin nice and plump and firm. We start to see wrinkles. We start to see the degrading of cartilage, like all of that sort of stuff starts to happen. So yeah, we see the compromise of the structure of the airway, but also what starts to happen the older we get when it comes to strength. All right, we experience global unless you are, guys, if you don't use it, you lose it, right? If you're still 70 and you work out every day or you go for a walk every day, you're still gonna have strong muscle tone, right? But the older we get, the less mobile we get, right? We sit down more. It might be because we've got arthritis and it hurts to move type thing. So we experience overall muscle atrophy. A-T-R-O-P-H-Y. That means the muscles get smaller and they get weaker, right? And that's everywhere, all types of muscles. Okay, so that muscle atrophy that we see, you know, with the muscles we use to control our airway, same thing, all right? The elasticity of the lungs decrease. Again, we run out of the strength of the ability to control our airway, the muscles we use for that, all right? We start to lose coordination. So a lot of times you will see these elderly patients be put on a specific diet because it's harder to chew and swallow their food, and they don't want them to aspirate or breathe in that food to their trachea, okay? So, yeah. Surface area of your alveoli decreases over time. Again, we lose that elasticity. We lose the composition that was nice and tight when we were adults, and now it's just starting to kind of relax. Why is that bad? Yeah, it takes away your surface area. Let's say you had 500 square feet in an adult alveoli. Not true, right? But just a comparison. And all 500 square feet of that was utilized for that gas exchange. Getting CO2 out, putting O2 on, right? But if that decreases down to 250, we don't have as many spots and as much ability to have that gas exchange occur, right? So our O2 levels can go down. Our CO2 levels can what? Increase, because we're not able to offload it from our system, right? That's another thing that comes into play with COPD. I'll talk about that later, but it's not.
Does consistent exercise prevent this to a degree?
To a degree, yeah. I mean, you're not going to be able to like run away from time, but yeah, if you're consistently like just at least walking every day, you're using the muscles, you're promoting that blood flow. So yeah. Delay or decrease the intensity of, yeah. All right, so we talked about the aspiration because everything's just kind of more floppy, right? It's not as toned, we can't control it as well. The muscles become stiff, they're not as strong. All right, so how might this, if we've got a combination of a high aspiration risk and weakened muscles when it comes to my respiratory system, why might that pose for a bad, lethal, a lot of times, combo? Inability to recover, because, okay, we didn't talk about with the immune system with kids. Their immune system is not 100%. Why? They're still new. It's still maturing. It's not functioning at its prime just yet because it's still working to get there, right? Geriatric patients also have, they're immunocompromised. Their immune system doesn't work as well. Why? It's just starting to degrade. It just doesn't work right. It's fully developed, but it's just starting to kind of come apart, if you will. All right, so if you start to aspirate something in your trachea, we talked about it yesterday, what do you immediately do? You cough, and 9 out of 10 times, what happens to either the liquid or the solid that was going into your trachea? Boom. You can get it out, right? That's the body's way. That vigorous coughing is trying to forcefully expel whatever was stuck in the trachea. High aspiration risk for a floppy airway and the inability to have that strength to really cough it out. All right, this is how geriatrics develop pneumonia very easily. Because if something goes down into your trachea and it doesn't totally occlude it, you don't, choke to death, it will settle down into your bronchi or your alveoli or wherever it fits. And if you don't cough it out, if you don't get it out, it sits there. What happens to it? It becomes a source of infection. It's a foreign body. It should not be in your lungs. And you start to have your immune system try to attack it, try to get rid of it. And guys, when the body tries to get rid of something and it kills it off, it gets rid of it in the form of like mucus or sputum. All right. Again, fester in their lungs. They can't cough it out. They block all of those capillary walls. They're not having any gas exchange occur, and they can't recover from it. So that is why you hear all the time a common cold, the flu. It always develops, or not always, it likely develops into that pneumonia, and that's what kills these geriatric patients off. That's what can kill these pediatric patients off. And again, that's what we're seeing with COVID-19. It's directly affecting these immunocompromised patients that can't expel the stuff from their lungs. It's attacking their lungs. They can't recoup, they can't recover. Okay? Does that make sense to everybody? So your endocrine system, all of your hormones start to, drop off the deep end. Your insulin production as well, that can change your sugar levels in your bloodstream. Your metabolism decreases. You start to see two things happen with geriatrics. They either get really teeny tiny or they gain weight. Why might they get teeny tiny? They don't eat. Why might they not eat? Maybe too much effort to chew it up and swallow it. Yeah, that might be why, but why else? Okay, so maybe forget to eat. Guys, we talked about these senses that start to go away. Your taste.
Because some people just aren't as hungry usually when they get older. Their digestive system changes.
Yeah, it's a lot slower, but you can't taste things as well, right? Now that's going to be the day that my soul dies. I love to eat. I love food. All right, so if I'm not going to be able to taste, or you start to gain weight because your metabolism slows down, you're still eating at a normal pace and your body can't digest it and process it, and you gain weight. Also too, if you're immobile, you're not moving around as much, you can't burn off those calories. Okay. Reproduction in males, you are still consistently reproducing sperm. You can still reproduce up until the age, I guess until they die, right? It's like Hugh Hefner had a kid at 77 or something like that. Sexual drive starts to go down for some. Yes, you might still see 8-year-olds who are still sexually active. But again, overall, it's not the best time, I guess, to talk about this particular thing in the sexual activity. But overall, globally, mucous membranes start to dry up. All right, so in your nose, in your mouth, and other orifices, it's not that I guess, habitable and moist environment. So everything kind of comes all together. Again, we can't taste as much, that those mucosal membranes, we don't produce as much saliva, so it's a little harder to eat. Our intestines, they start to move slower. Anal sphincters, talk about those, okay? What is your anal sphincter? It's your rectum, okay, if you didn't know that, but what is it made up of? Muscle. What did we talk about globally in your body happens to your muscles the older we get?
Yes, we do.
They get weaker, can't control them as well. All right, so that's why we start to see this, what we call incontinence, the inability to control your bowels or your bladder, because the urethra is extremely muscular as well. That's why you can like hold your pee. If you can't pee right there, you can be like, how do you hold it? I got it. It's got a muscular component to it. So if those muscles are not as strong, we can't control them as well, then we start to see, you know, the incontinence. So can't wait to get older, right? Your kidneys, they don't work as well either. They physically get smaller. They just start to shut down. They can't filter out all of this waste products. They don't create as much urine. If we're not getting rid of these waste products via urine, they start to build up in our system. We can see problems there. Nervous system, again, we've already kind of talked about that. We start to have that forgetfulness in most cases, guys. There's 95-year-olds out there who are just totally still 110% with it, right? Not everybody gets Alzheimer's or dementia, but it is a lot more common than not in these geriatric patients, okay? So you can see here, guys, the mass of your brain, the surface area of your brain physically gets smaller the older we get, okay? So here, all of this white and gray, this squiggly looking stuff, that's your brain, okay? This right here is depicting your skull. So notice here in an elderly patient, it's a lot smaller. There's a lot more space in between your brain and your skull. All right, this is what can lead to some significant problems when we talk about trauma. We'll talk about that. But yeah, the smaller the brain mass, the less neurons are firing. That's why we start to see Alzheimer's and dementia. We've already talked about sensory. The pain sensories are diminished. That's why I had that little old lady who jacked her ankle up and she didn't think anything was wrong. She couldn't feel it, right? Which also goes into, somebody over here said that they are consistently cold all the time. All right, so that sensory nerve kind of goes into play for that, but also they don't have as much of that collagen, the insulation that helps keep us warm. It starts to kind of deteriorate as well. So it might be 100 degrees outside, but you walk into, you know, this elderly patient's house and it's literally 78 degrees and they're wearing like 3 blankets. Okay, that's not uncommon at all. Reflexes, right? All of the sensory nerves decrease. We lose the strength of those muscles. So what is significantly decreased overall with geriatric patients? Reflex time, right? You know, which is why it would probably be wise that at a certain age you have to retake your driving test. Because A, you don't hear as well. You might not hear somebody honking at you. B, you don't see as well. You might not be able to tell that that light's red. And C, your reaction time to physically pick up your leg and put it on the brake is significantly increased, all right? On the same accord, if you're walking and you trip over something, your reaction time to physically get your arms up and brace yourself and catch yourself is significantly increased. So we see a lot of facial and head trauma in geriatric patients who fall because they don't have the reflexes to catch themselves. If they do, we see a lot of broken bones. Why? Osteoporosis, right? That brittle bone, they're not as strong, they're not as durable, they break more easily, they shatter more easily.
Do you find a balance issue in older people?
Yeah. And that is attributed to the smaller brain mass, and there's a fluid level disturbance because of that. So they're
I
not
know I
as,
see it in my grandparents, but I don't know if that's just in general.
yeah, I mean, I wouldn't say every single geriatric patient does have those balance problems, but it is very common. Yeah. Else, what was I talking about? Shoot. Okay, it left me. All right, psychosocial changes, guys. You would be very surprised at the amount of, I mean, I guess you wouldn't be surprised, but older people tend to become depressed. Why? They're lonely, right? Why? Why might they be lonely? Okay, so
Don't have much family around them.
yeah, okay, so people around them, maybe a spouse, maybe friends, maybe siblings that were close in age have maybe passed away, they're not there anymore, right? What else? Your body's literally falling apart, right? What else?
Isolation.
Isolation, medication can cause some depression, but isolation, yeah, guys, unfortunately, our society does not value the elderly, and it sucks. If you go over to different countries and different cultures, oh, they are taken care of like kings and queens by their family, right?
In Southeast Asia, elderly people get to go to the front of the line no matter what.
Yeah. We don't do that here in America.
I mean, you know,
Cultural faux pas over there.
Yeah, so there is a social, you know, removal if you're not working and you're not socially around people anymore. What'd you say, whoever over here?
No, I was saying it's like a social faux pas in like a lot of cultures to not take care of your elderly.
Right, not here, right? What do the elderly generally become? Not guys, generally, they're obviously, this is not every single case, but you will see this so much in the healthcare field. What do the elderly become here?
Shut-ins.
Shut-ins, okay, if they're lucky, if they're living at their own home, right? They become burdens. It sounds very,
Dark.
and for me to say this and very harsh, but it's true, and you're going to see it almost every day you work here. All right, because they can't care for themselves, or they're starting to have this incontinence, or they're starting not to be able to remember everything. They become a burden to their family because they can't take care of them, or they don't want to take care of them, or it's too much. Where do they go?
Nursing homes.
Nursing homes, right?
Assisted living.
If that happens to a family member who physically is still not being able to care for themselves, but mentally is intact, and they can see what's happening, like their family's just writing them off, and now they come to see them once a month. That'll, right? So we see the depression. Guys, just if you get a geriatric patient, just talk to them. You would be so surprised. They just want somebody to talk to. Just talk about, you know, the weather, talk about whatever. All right. So speaking from personal experience, that's one of the biggest regrets with me and my grams. I didn't do that, or I didn't do that. So just talk to them. They might be fine, and you might lift their spirits up 1,000 times just by having a conversation and treating them like a person.
Ask them about funny stories.
Yeah,
They're living in
you
their
can
era.
learn
Oh,
so
yeah.
much. They've got such cool stories.
You might need like the most awesome
Right.
I used to think my grandma was like the sweetest lady ever, and then she told me a story about how the street part tore up roses when they put in gutters on the side. And she went out and whacked one of them with a shovel. And like, I was like, "You really did that?" She's like, "Yeah, messed up my roses." I was like, "That's amazing."
Awesome. Yeah.
You'll be
So
amazed. You'll be amazed at what you learn over a game of dominoes, yo.
right. All right. So just keep that in mind, because guys, if we're lucky slash unlucky, this is going to be you one day, right? We're going to get older. We're going to go through this stuff. Nobody is inevitable from this. So just keep that in mind. To end on such a positive, uplifting note, questions, comments, concerns? Okay, so guys, major takeaways, the vitals, differences, and the different health complications that we can start to see / what's to be anticipated and expected, especially with the geriatric population, maybe with the pediatric population as well. Okay. Everybody good? No good over here?
Yeah.
All right.